Okay, so good afternoon, everyone. My name is Sharice. I am the Executive Director for the Down Syndrome Association of Pittsburgh, or DSAP. We are so happy to be able to offer this program to our community. Just a couple notes before we start. We are recording, and we do put this recording up on our website after the session is over, so you'll be able to go back to it afterwards. On our website also are past recordings from other speaker series we've done, as well as, sorry, as well as where our programs and our events are posted. So if you're looking for other things that DSAP is doing, check that out. You can also check that out on our social media, both on Facebook and Instagram is mostly where we're posting those things. The other thing is if you have any other topics that you're looking or you're interested in, we would love to hear from you. So if you can send an email to info@dsapgh.org, let us know what you're looking for, and we'll see if we can make that happen for the speaker series. So I think that's all the notes that I had. So today we have Dr. Taryn Santamaria with us. We're honored that she's able to join us. She's the psychologist at our Down Syndrome Center here in Pittsburgh at Children's Hospital, and she is going to be speaking on Down syndrome and their behaviors. So without further ado, I'll pass that over to Dr. Santamaria.
All right. Hi, everyone. I'm just gonna see about sharing my screen. Okay. Can you see this? Is it in presenter mode? Okay, wonderful. So I am the psychologist in the Down Syndrome Center. Just before I start, I just wanted to give a little disclaimer that today is just for educational purposes. This is not considered treatment for your individual or yourself, and please consult with your existing medical team. Just a little bit about myself and my background. So I have my bachelor's, which I got from WVU, bachelor's in psychology. And then I came to Duquesne University in Pittsburgh to receive my master's in child psych and my doctorate of psychology in school psychology from Duquesne. In terms of licensure and certificates, I'm a state and nationally certified school psychologist and also a PA licensed psychologist. At the Down Syndrome Center, I'm the psychologist, and then I also have a clinical assistant professor position through the School of Medicine at the University of Pittsburgh. In the Down Syndrome Center, the way that our clinic works is that an individual with Down syndrome must first see one of our medical doctors before getting to see me. And we'll kind of go into the reasons behind it in a minute. Appointments with me can be either in person or virtual. The virtual platform that we use is called MyCHP. It's the app. I'm located at the main hospital at Pine Center in Wexford, which is where I am right now, or Children's South, which is in Bridgeville. Unfortunately, if you live outside of the state of Pennsylvania, I cannot do virtual appointments because I'm not licensed in other states. But if you live in another state, you can come in person to see me. Initial appointments with me are considered a psychological evaluation. And during those appointments, I'm going to be asking tons of questions about background history, caregiver or parent concerns, symptoms or needs. And then if there's a diagnosis, we'll discuss that. And if I have treatment recommendations, those will be given at the time of the evaluation appointment as well. So oftentimes I'm making recommendations for individuals to see me for outpatient therapy. Sometimes they are outpatient therapy sessions might be focused on parents and caregivers and not so much one-to-one with the individual. I also make recommendations for IBHS or what we call wraparound services or ABA services in our area. And then there's higher levels of care like family-based that I can make referrals for as well. So the initial appointment with me is blocked off for like a 2 hour window. It doesn't always take that time, but sometimes it does. The individual does have to be present for that initial appointment, but then subsequent appointments when they're outpatient therapy, sometimes if it's just me and the parents consulting about behavioral strategies, for example, the individual does not have to be present for those. And those appointments can range anywhere between 15 and 60 minutes, but normally the average is about a 45-minute outpatient therapy session. And then outpatient therapy sessions can be at whatever frequency you or your family might find to be most helpful. So there's some individuals or families that I see once a week. Sometimes it's biweekly, sometimes it's once a month or just as needed. I'm really flexible and will try to support in any way at whatever frequency works for your families. And what's been really nice since the pandemic, prior to the pandemic, we never allowed or were allowed to do telehealth. And then when the pandemic happened, telehealth was permitted. And I've been able to reach a lot more families who do not live close to our centers. The other really cool thing that's been happening since telehealth has been permitted is that I have a lot of teachers that'll hop on telehealth appointments. So when there are a lot of behavioral concerns at school, we can use an outpatient therapy session, like a brainstorming session, and try to bounce ideas and or provide education or support for teachers as well. So that's been really neat. To schedule an appointment with me, you can call our Down Syndrome Center at 412-692-7963. Option 1 is Camille, and she's our scheduler. Or if you prefer to talk to Erin, she's option 3. So there's some reasons why we do a medical appointment first and why that's a requirement. So individuals with Down syndrome tend to have a pediatrician. Then they have a physician that specializes in needs related to Down syndrome. There are specific American Academy of Pediatric guidelines for individuals with Down syndrome, and there's a child version and an adult version. And in them, it lists different tests or examinations or things to target at different age ranges. And those things might not be things that are done as part of a typical well visit with a pediatrician. So it's really important that your individual sees one of our medical doctors. And then the frequency of appointments kind of spreads out with age. It's more frequent for babies, and after 1 year, it becomes annual. But our individuals have a lot of really complex medical needs and things that need to be checked. And then also medical needs can contribute to emotional or behavioral presentations. So it's really important to check off and make sure that it's not the medical concern that is causing a behavioral need. And some things are like some of the biggest ones that I see in my clinic are sleep apnea, thyroid disease, and constipation. Those tend to result in a lot of behavioral concerns. So for example, if your individual's really constipated, then they're probably not feeling great and become more irritable, and then there might be more tantrums or outbursts as a result. If your individual is not getting quality sleep, it's kind of the same thing. If individuals aren't getting great quality sleep because they have sleep apnea and then they're tired during the day, you might notice more refusals or stop and flop or tantrums. So there's a lot of things that we need to rule out before we determine if there is mental health or behavioral health related concerns. So common concerns that I see we call it the behavior clinic. There's not really a really great name for me, but it's just when I see patients or clients, some of the common things that I see are anything related to toilet training, anything related to sleep issues, emotional concerns like anxiety or low mood, the stop and flop, which I'm sure that you all know what this is, but maybe call it something different. Sometimes it's when the individual sits on the floor and refuses to move. And sometimes they have spaghetti arms and cannot be moved by the caregiver. There's sensory seeking or stimming or sensory aversions, a lot of power struggles or limit testing, some darting and elopement, lots of difficulties with transition, sometimes aggression. We have something called the Down syndrome groove, which is oftentimes very functional, repetitive behaviors or like a need for sameness and routines, which can be functional and no big deal. But then sometimes our individuals then have difficulty with transitions, or the groove becomes so time consuming or unable to be interrupted. And then it goes into like OCD land where it becomes more problematic and disruptive to their lives. I do a lot of education about safety, so personal and environmental safety. I present on this topic too. I'm presenting on that at the NDSE conference in July, which is in Dallas, if anyone's going. I see a lot of individuals with concerns of refusals, tantrums, any behavioral needs at school. And then because I'm a school psychologist, I do a lot of um, work around educational advocacy. So, talking with families about inclusion, educational evaluations, behavior plans, FBAs, that kind of thing. I forgot to mention, please shout out. I can't see anybody when I'm doing this presentation, so feel free to raise your hand or to shout out and ask questions whenever. I'm totally okay with you interrupting. Um, so some things to consider kind of prior to talking about behavioral concerns and prior to designing behavioral interventions, not only am I thinking about possible medical etiologies or causes, but I'm also considering, uniqueness to our community. So any learning or cognitive needs, I'm thinking about language, like expressive and receptive language needs that we might need to attend to when we're designing interventions, learning style. Is there an area of skill deficit that might be contributing? So, for example, individuals that might not know how to initiate an interaction with someone else might do something like push to get an interaction, a play interaction with another kid. So it might look behavioral when you see someone pushing, but if there's a skill deficit like how to greet another, how to ask another to play, whether it's verbally or non-verbally, we need to make sure to teach that skill and practice it before we can um, expect the pushing to decrease. Another thing that I'm always considering is was there a sudden change in presentation? So, for example, if all of a sudden we're noticing a really low mood or lots of anxiety or a very big change in behavior, then I kind of go through my medical checklist again, or maybe it's worth a touch base with one of our medical providers just to make sure that there isn't something going on. So this is common for like ear infections or dental needs, things that maybe our individuals aren't able to tell us and is greatly impacting. When we think about behavior change, some things that we have to also recognize is that behavior change takes time. This is not something that is going to be overnight or we implement a strategy one time and expect perfection. There is a saying that like you can't walk 5 miles into the woods and expect to get out in three. It's something that takes a really long time. And when behaviors are well established, it might take even more time to kind of unravel or rework those. When we implement a new intervention, sometimes families or teachers will implement it a couple times and say it didn't work, and then they'll stop using it. But really, we should be implementing them for a long period of time. And when people ask me what does long period of time mean, I might say like 3 months before we determine if it's working or not. And it might not work 100% of the time. We all have bad days. What is really important is that we implement an intervention that is implemented by all caregivers. So consistently every single time with fidelity means as designed. So if it's an evidence-based intervention, we want to do it as the intervention was designed. Sometimes when we implement an intervention, we can expect behaviors to increase before they get better. And oftentimes, this is really scary for parents. So, for example, when we implement planned ignoring, which is planfully ignoring attention seeking behaviors, oftentimes our individuals will do things like they'll kind of like pull every tool out of their toolbox and do more and more attention seeking behaviors because they're like, wow, that didn't work. Now I'm going to do X, Y, and Z. So in my office, sometimes kiddos will stand on the chair and I might use planned ignoring, and then they'll try to get up on the table, or they'll become more intrusive with the parents and like sit on their lap and touch their face and move their face to them. So it might get worse before it gets better, but when the individual realizes that they're consistently not going to get a reaction or attention for that, it'll eventually decrease. So that's called an extinction burst. And sometimes that's really hard to weather, but don't give up. I always focus on proactive or preventative strategies. as opposed to reactive strategies. If we can prevent the behavior from occurring or decrease the likelihood of it occurring, it is far easier than trying to decide how to respond appropriately each time. And I don't focus on like punishments or consequences. It's just not as effective. When I do behavioral interventions, I always have this mental checklist. And so my mental checklist tends to be not only, okay, could this be medically related and the person's learning style or maybe their cognitive profile, but it's also the functions of behavior. So functions of behavior is like the why. Why is the behavior happening? First, we have to figure out what that function is before we even intervene. And once we know that function, we'll know how, like what strategies to use. So oftentimes when we talk about functions of behavior, you might have heard this in the context of ABC data. And sometimes at schools, especially, they do what's called a functional behavioral assessment, which is just a fancy way of saying, we're going to figure out what happened right before the behavior, what the behavior was, and what the consequence or what happened after the behavior to determine what the function is and to determine what interventions or strategies would be most helpful. So ABC stands for antecedent, behavior, and consequence. So the four functions of behavior are attention seeking. To obtain something tangible, this would be like a kiddo who wants access to the iPad or wants an extra treat. To escape or avoid something non-preferred, this might be like a kiddo who does a behavior to get out of doing classwork or to delay bedtime or to not have to go to the bathroom. And then there's also sensory needs. So this could be sensory seeking or sensory aversions. Were there any questions so far? Okay. Um, so with the functions, I'm kind of going to break it down a little bit more. So, attention seeking, and this is a behavior that causes the individual to gain a reaction or attention from others. This can be positive or negative. It oftentimes is resulting in negative attention, unfortunately. The behavior can occur at any time that the individual wants social interactions with others. So, for example, this might be an individual that darts from a caregiver while also like looking back and laughing, and then it becomes a game. It could be an individual that shouts out or uses inappropriate language in the classroom. It oftentimes gets big reactions. For example, when an individual is darting from a parent or caregiver, the parent oftentimes is very worried that they're going to become lost or hurt or that it's unsafe. And so then they are maybe shouting and telling them to stop and then running and chasing. When an individual is using inappropriate language in the classroom, the classmates may then laugh, which then gets the individual gets attention, and then it results in the behavior occurring or likely to occur more often. So how would we respond to behaviors that have the function of being attention seeking? The number one intervention is planned ignoring. So this is, we're going to planfully ignore attention-seeking behaviors. So that means if the individual comes to my office and they're saying swear words, I am going to not make eye contact. I'm not going to look at them. I'm not going to tell them no or stop. I'm not going to use the mommy finger. I'm going to pretend like they are absolutely invisible. Now, the likelihood that they will say it more or closer to my face or become more colorful with their language is probably high, because that's that extinction burst. They're like, wow, like this didn't get the reaction out of her that I was expecting. So now I'm going to up the ante a little bit. But eventually the kiddo's going to get tired of it and bored. There's no audience for them to feed off of. So then it'll decrease. You're probably thinking, well, I cannot use planned ignoring if my individual is darting towards the road, and you're absolutely right. So there's a modification when behaviors are attention seeking but unsafe, and this is called the respond but don't react method. And you all may have become familiar with the book by Dr. David Stein called Supporting Positive Behavior in Children and Teen with Down Syndrome. The respond but don't react method. This is the behavior book that our medical doctors and myself recommend all the time. And it kind of, Dr. Stein coined this term called respond but don't react, which means If your individual is doing something attention seeking that's unsafe, we will go and bring them to safety, but we're not going to make eye contact. We're going to keep our face neutral. We're not going to say anything. We're not going to say no or correct or reprimand in any way. Because it's not a teachable moment. And any type of even correction, even if you're saying, don't do that, that's not safe, or, that's not allowed, it's too much attention. And so it'll increase the likelihood of that behavior happening again. It's called inadvertent reinforcement. So we're going to use that planful ignoring, but make sure that the person is safe first. There is a phrase called differential reinforcement, and that is teaching someone what they will get attention and reaction for, like all the good things, and what we will not get attention for, like all of the challenging behaviors that may be attention seeking. So, for example, if someone were in my office and we're standing on the chair and making silly faces and swearing, I'm not going to give any attention to that. But the second the individual stands on the floor or the individual sits on their bum, I'm going to lay it on thick like they just did the most amazing thing in the world. I'm saying, great job sitting with your bum in the chair. I love how you put your feet on the floor. I'm just going to let them know that's what I want to see by giving them attention and a really positive reaction. But I'm not going to give any reaction or attention to the standing on the chair. So when I was talking before about making sure to identify areas of skill deficit, oftentimes when an individual is doing negative attention seeking, it's because they don't know how to do it in a positive way. And so teaching our individuals how to gain attention appropriately is really important. And whether this is greeting, asking to play, teaching our individuals how to tap on the hand rather than get in the face and make silly faces, this is something that needs to be taught and practiced in a neutral moment, not in the moment where they're having misbehavior or this attention seeking behavior, but in another neutral moment. Any questions about that before I move
I
on?
have one in the chat here.
Yeah.
It says, my child loves attention. Some of her peers know this and may encourage her to say bad words. Then they laugh, and Lauren thinks, great, I've made friends laugh. How do I help my daughter
Mm.
understand not to do as they say?
That's really tricky. So sometimes class clown behavior is age and developmentally appropriate, but what's tricky is that our individuals oftentimes don't know when to stop or don't know in which audience. So, for example, if your individual were a teen and were swearing amongst their peer group, I'm not as concerned, but oftentimes what others understand is, oh, when the parent or when the teacher comes around, we have to stop. But our individuals will keep going. The other thing is in a class, when other people find it funny, it encourages the behavior. So oftentimes I'll have ask the teacher to talk to the class, and they might say, hey, I'm using planned ignoring, and this is how you can do it too, because we need to get other people on board to get them to stop reacting or responding or laughing, because that encourages the behavior to keep happening. So if the teacher can model the use of planned ignoring and maybe help get the other students on board too, I think that will help to decrease the behavior. But then also in a neutral moment, teaching the individual how to get attention from their peers in a more appropriate way would be a really good place to start.
Two more things.
Sure.
The original comment that I just shared, she said that her daughter is 11.
Okay.
And then the second question is, my daughter is 8 and scratches in school for attention.
Mm-hmm. And so I need more context. Oftentimes, people will be like, "Oh, well, my kid scratches," but I want to know what was the antecedent, like what happened right before, and then what was the consequence, what happened right after, because just saying scratches doesn't let me know 100% that it is for attention. But assuming that is the case, then I would want to know, okay, well, is it because your individual is trying to play with someone and isn't necessarily knowing how to go about that appropriately? Is it because the person is trying to tell someone else they don't want to share that toy with them? Is there a social skill or a communication skill that needs to be taught? And once those are practiced and rehearsed and become mastered, will that scratching stop? But I really need more information to really know for sure.
She also shared, I told her teachers to ignore, but they will stop if it's unsafe. I think it's sharing and communication.
Okay. Yeah, and oftentimes, so it's kind of like maybe it's one of the situations like respond but don't react where we don't want other kids to become injured. So what they could do is they could use planned ignoring of the individual, take the other kids away so that they don't continue to become scratched. Creates a little bit of distance or space, but then ignore the behavior. So the respond but don't react method might be helpful there. Any other questions? Okay. The next function of behavior that we're going to talk about is called to obtain or to obtain something tangible. So this is any behavior that's done to gain access to like a highly preferred item or activity. In my clinic, I hear oftentimes it's because I want an electronic or because I want a sweet treat, or I want to go see my favorite person. So it's done during a time when the individual desires something specific or a specific activity. How we would respond to that. So, well, first, like an example might be so if the individual was told that they couldn't have dessert, but then they were trying to steal more out of the kitchen, or um, a tantrum when the parent says no, that they cannot have their tablet, for example. Um, if it is not okay for that individual to have that item, then the intervention is really to remain consistent, to not permit it, to not allow access to that desired item or activity. So oftentimes what happens is that parents will tell me, well, my individual is really persistent and they will repetitively ask until like I'm worn down and stressed and tired, and then I give in to avoid further escalation. That happens pretty often, but remaining consistent and having firm limits and boundaries is really important. Um, Making sure that we're, again, thinking about skill deficits, communicating, helping the individual to communicate their wants and needs. And this doesn't mean just verbally. This could be non-verbally or using the AAC device, whatever mode of communication your individual uses. We're also going to practice waiting and practicing how to accept no. These are really difficult. Oftentimes, our individuals don't like being told no. What person does? But and then teaching individuals to wait. So maybe they can have X, Y, and Z, but just not this moment. But in this moment, you need them to get a bath first. Using like a first then phrase could be really helpful. First, we're going to get a bath, then you can have X, Y, Z. Um, Okay, so the next function is to escape or to avoid something non-preferred. And this is done to remove themselves from an undesired situation or person, to avoid a specific task, to escape a non-preferred environment. It often occurs at a time when something is viewed as too hard, too boring, too loud, less preferred than something else. And then, so examples might be, I'm thinking in the classroom, they're given a math task, like a math worksheet, and the individual maybe throws their pencil, goes under the desk, does the stop and flop, or maybe just does verbal refusals, just saying no, or passive refusals, ignoring the parents or ignoring the teacher. So, how we're going to respond is we're going to remain consistent with the demand. We're going to follow through. We're going to be consistent and persistent. We might think about giving the individual choices. So a lot of times our individuals don't have a whole lot of control, and are seeking independence, and it can turn into a power struggle. But if we give choices, for example, I love giving choices in a morning or an evening routine. So if the individual needs to go to the bathroom and brush their teeth. If it doesn't necessarily matter which one they do first, then I'll say, hey, do you want to go potty first or brush your teeth first? In the classroom, if there's some flexibility in the schedule, it might be, you've got to do these two activities. Do you want to do reading first or math first? Giving that choice gives a sense of power and control and can really motivate an individual to complete those tasks. So choices whenever possible. Also considering chunking assignments, which is like breaking it down into smaller parts, breaking down tasks into smaller parts. is oftentimes really helpful. So it's not so overwhelming or daunting. And then also teaching an individual to request a break. There's times when our individuals are doing a lot of really hard work and they might need a break to regroup or to get some really good sensory input and then come back to be able to do the activity. Just don't give a break in response to a challenging behavior, because then that might teach the individual to do a challenging behavior. That's what gains them a break every time. So teaching them to request a break instead. So the last function is sensory. So the behavior provides access to sensory stimulation. Sensory seeking behaviors are really self-reinforcing. Sensory can also mean like avoiding aversive stimuli. So for example, a lot of our individuals have noise sensitivities, and so they might do a lot of darting or elopement out of the gym or the cafeteria, or increased behaviors on the school bus because they're averse to that sensory stimuli and they're trying to like get away from it because it is so problematic. So it ends up being like a mix of sensory plus escape or avoidance sometimes. The behavior happens at any time in the presence of an audience. Sorry, my spelling on this was wrong. In the presence of an audience, or when an individual is all by themselves. You may notice it more when the individual is passively rather than actively engaged. So this means like when an individual is maybe riding in the car or just watching TV, so not actively doing something, we oftentimes see sensory seeking behaviors increase in those moments. We also notice it a lot after school and before bed, so that might help clue you in to the function being sensory as opposed to something else. We also may notice it when the person is increasingly tired or stressed. So a lot of our individuals do like climbing, jumping, running and crashing against a couch, a lot of flapping, rocking, spinning. We have a lot of individuals that dangle items and watch it, or vocalizations. These are self-reinforcing, which means it feels good to their body, which then increases the likelihood of it happening. There's very few moments when I think that this requires any intervention or behavioral response at all. The only times where I become concerned if it were unsafe or really disruptive. So, for example, if the individual is like mouthing and trying to ingest rocks, if the individual is vocalizing so loud that it's disruptive in the middle of class. What I'm going to do is probably consult with an occupational therapist. Sensory seeking is like OT land in their wheelhouse. So I'm going to try to figure out what's called a sensory diet. That's like an assessment of an individual's sensory preferences. And then once we know those, we can design really efficient or effective ways for an individual to gain sensory input. And so if an individual is doing tons of sensory seeking in the classroom, well, can we plan a break right before hardcore academics where they can get a lot of really good sensory input, and then maybe the likelihood of that happening in the middle of instruction would decrease. There are things called incompatible responses. This would be like if an individual gnaws on their finger a lot and it's causing like breaking of the skin. Well, can we put gloves on the individual, or can we have them busy their hands and they don't have access to putting their hands in their mouth? There's also replacement behaviors, like if the individual is chewing on their hand, can you give them a chew tool instead? Oftentimes, what we have to do is match it really closely. So oftentimes, in caregivers will say, oh, well, my individual is doing X, Y, and Z, so I gave them a sensory tool to chew on. Well, if X, Y, and Z wasn't chewing or mouthing related, it is so unrelated that it doesn't really serve the purpose that you're thinking it does. We have to make sure that that person is getting sensory input in the way that they need it, but that it's more efficient or effective. Okay, any questions before I move on? Okay, so I'm going to give some random examples. If this sounds like your individual, I promise that these are random and I wasn't eavesdropping or using a patient information. But here's a situation, and then I'm going to ask you what you all think the antecedent, the behavior, the consequence, and the function is. And so just a reminder, consequence doesn't mean punishment or what the parent did, like giving a timeout. It means like what happened after the behavior occurred. Um, so the situation is a parent is cooking food for the family and is also assisting a sibling with homework. The individual with Down syndrome gets rough with the family dog, pokes the dog, pulls the dog's ear. The dog growls and barks, and then the parent shouts at the child not to harm the dog, like, oh my gosh, don't hurt the dog's gonna bite you. And there's kind of like this excitement from the situation. So if we had to guess, what is the antecedent? Please just shout out. What happened before the behavior? Any takers? So this is the parent was busy cooking and doing homework with the sibling. That's the antecedent. What about, yes, Kathleen, I saw a parent paying attention to the sibling. What is the behavior in this situation?
Well, they're trying to get your attention. So it's attention seeking.
So that would be the function. The behavior would be like the aggression towards the dog,
Oh,
like the
okay.
poking, the pulling, the ears, but the function, sure, the function is attention seeking, just skipping ahead. Um, what's the consequence? What do you all think the consequence? So if the parent being busy, paying attention to the sibling is the antecedent, the behavior is the aggression towards the dog, the function's attention seeking, but what's the consequence?
Is it ignoring it and removing the dog so the dog doesn't get hurt?
Yeah, well, so that would be some of the behavioral interventions that we would try. The
Okay.
consequence is what happened right after the behavior. So the dog growled and barked, the parent yelled. So this is what the behavior caused to happen. So it kind of got that excitement from the dog and from the parent. And you're right. So when we think about, um, for example, what do we need to do behavioral intervention or say or strategy wise? Plant ignoring on this one is kind of tricky because if the kiddo keeps or individual keeps being aggressive with the dog, there can be safety implications, right? So we want to make sure to use that respond but don't react method and we would bring the dog to safety, not the child. We'd bring the dog away and ignore the child. And this might be bringing the dog into a gated area, into a bedroom, whatever it might be, and not saying anything to the child. So we're not saying, no, stop, don't do that. The dog's going to bite you. We're not saying anything. We're not looking at the child. We are completely ignoring as if the individual is invisible, but we're going to bring the dog away so it doesn't keep happening. When we think about areas of skill deficit or what we may need to teach, what do you all think there? My thought would be how to gain attention appropriately. So the child is right now understanding if I, misbehave with the dog, I get attention, but we need to teach them how to do it a different way. Yes, I see Ashley and Kathleen. We're going to more appropriate ways to get a parent's attention. Also teaching how to play with the dog. That's a really good point. Like animal safety might be something that we really need to address. And what's appropriate way to care for a dog so that way it's not harming the dog or going to result in anything unsafe. Okay, let's go to the next one. The individual attempts to take the parent's phone. When the parent tells the individual no and puts the phone in their pocket, the individual becomes more intrusive. The individual escalates more, starts yelling, grabbing at the parent, becoming dysregulated. The parent continues to deny access. So, what's the antecedent to this? Like, what happened before? Or what was like the first thing that happened before the behavior got worse? We'll start there, maybe.
The mother was probably on the phone.
Yeah, maybe the parent maybe was just like holding their phone. The child saw it and then decided they wanted
I
it.
mean, if my kid doesn't get what he wants, he just takes the phone and throws it, whoever's it
Yeah,
is.
yeah. Well, and I mean that I think it might be a slightly different behavior too, because that probably does get a big reaction out of people. But also, was that done because the individual, he wanted something and wasn't getting it. So it may have been to obtain an item or activity. So the behavior in this situation is the intrusiveness, the escalating, the yelling, the grabbing, and then becoming more dysregulated, which might be like escalating to a tantrum, for example. The consequence in this situation, what do you all think? So the kid wants the phone, the kid starts to have misbehavior, becoming dysregulated. Then what happened? Yeah, the parent denies access. The parent was trying to remain really consistent and saying, like, no, you may not have this phone. And this is not an attention-seeking behavior. So it's okay for a parent to say no or to give a reaction or attention to this. And the function, what do you all think the function of the behavior is? Like the why behind this one? The function is to obtain something tangible. So the individual wants the parent's phone. And the behaviors are occurring because they are trying to get it and want it. So areas of skill deficit or the target of teaching in this situation, I think it would be a really good idea in a neutral moment, not right in this moment, but would be teaching how to accept no, teaching how to wait. Our individuals might need some practice with how to occupy their free time independently, possibly like independent play without the use of an electronic, teaching functional and imaginative play. Also, like some basic emotional regulation or coping skills could also be really helpful. So that way, rather than escalating to level 100 because they didn't get access to this phone, but also like the ability to intervene early and regulate and calm themselves and then wait until it is permitted. Okay, so all of a sudden it stopped going. Oh, here we go. Individual situation number 3. The individual lays on the floor, the couch, the bed. We notice gyrating, vocalizing. This is observed in the living room, in the bedroom. It's been observed in the sensory room at school. At school, the teacher becomes alarmed by this and labels it humping. The individual is removed from class when it is observed in the classroom. What do you all think about the antecedent for this one? I think this is tricky. This one, I don't know if there is an identified one. I think it might be kind of like internalized and maybe not something super obvious to us. I don't know if there's really enough information. It could be related to boredom. I saw that message. It could be because there's increased internalized stress. Maybe the person's tired. So the behavior in this one is the gyrating, the vocalizing. What about the consequence for this? So what happened as a result of the behavior?
The individual is removed from the class.
Yeah, they were removed from the classroom when it occurred at school. It didn't really give any information about what happens at home. So what do we think the function is? I do want to point out that, it seems like it happens across environments. It seems like it happens when there is and is not an audience. So when the individual's by themselves and also with others. What do you all think the function is? So the function is sensory. This is sometimes a behavior that our individuals do to gain sensory input. It can be calming and regulating. Again, there's nothing wrong with it. It doesn't need behavioral intervention. I don't deliver any type of consequence to the individual. Like sometimes, again, like if the individual in this situation, an incompatible response would be to have the person stand up. They can't do this when they're standing as opposed to laying, but I don't really think it needs intervention at all. It's that individual's body is seeking that sensory input and they need to get it. There might be, we might think about planning breaks periodically throughout the day so that if they're in the sensory room at school, they can do it. At home, it's probably less of an issue. This is not, I should say, oftentimes it's not sexual or anything like that in nature. Although it seems like this teacher kind of assumed that. So we're going to educate others about sensory seeking and sensory aversions. If it's something that's super time consuming, maybe we'll set a time limit. Consulting with the occupational therapist, I think, would be really helpful as an ally or to figure out how the individual can get sensory input maybe differently or more efficiently. Okay, situation 4. The teacher presents an individual with a reading task. Oh, sorry, this thing is blocking. I can't read my own slide. Oh, did that skip ahead? The individual, sorry, I can't read the whole thing because my screen is being blocked. The individual's given a reading task. It seems like they went under the desk. There was other refusal behaviors. The teacher remained consistent with the demand to complete the academic task. The individual then eloped from the classroom. Eloping means like leaving this designated area. And elopement can be like leaving the classroom to go somewhere else or leaving the house or wherever they're supposed to be. The individual was taken to the principal's office as a result. So the antecedent, so what do you think happened right before the behavior occurred?
The request to do a reading task.
Yeah, they were given a task directive. They were given the reading task. The behavior was that they threw items, they went under the desk, and they eloped. The consequence, so what happened after the behavior occurred?
Taken to the principal's office.
Yeah, the teacher tried to remain consistent, but then sent the kiddo to the principal's office. You're right. So what do you think the function of the behavior was, or why did the behavior occur? Why did the throwing, going under the desk, and elopement occur?
Avoidance.
Yeah, so escape avoidance. I didn't want to do this academic task or this hard work. And it might not be like a really negative reason. It might have been, this is too hard for me. I don't understand. I'm getting academically frustrated. It's not just because the individual, or not always just because of like willful behavior. But yeah, it's escape or avoidance. One thing I do want to point out is that when the individual is given an out, such as being sent to the principal's office, that could actually accidentally reinforce the behavior. We call that inadvertently reinforcing the behavior. So if they get to go to the principal's office and don't have to do the work, you just rewarded them for refusing to do the work. Unless, of course, they're doing the work in the principal's office, but still, that's probably not ideal. An area of skill deficit or a target of teaching might be teaching an individual like time on task, we want to establish reinforcers or establish reinforcers or motivators, making sure that we're motivating the individual to complete the work. And this might be where we instill like a first then phrase. First we do this work, then you can have this more preferred activity or strategy. Okay, situation 5. Groups of students are walking with the teacher from the general ed classroom to the special ed classroom. The individual stop and flop, sitting in the hallway and refusing to move. Then the other students and teachers are passing by in the hallway. They're kind of doing some cajoling and coaching, like, come on, get up. You want to walk with me? Do you want to hold my hand? You can do it. Do you want to race to the next class? There's a lot of attention being given. So then the stop and flop persisted for a really significant duration of time. So, I'm going to go through this one a little bit more quickly just because I know that we just have 15 minutes left. But the antecedent would be the transition. There was a demand to transition between one classroom to the other when we know our individuals tend to struggle with transitions. The behavior is the stop and flop, the stopping, sitting on the floor, refusing to move. The consequence, or what happened after the behavior, would be all the attention from others. So this behavior gained them attention and interaction with other people. They had a really big audience in that hallway. So that function may have started as being escape or avoidance. They didn't want to transition, perhaps, but then it actually got maintained by attention. So it started as one thing, but then because they got all of the attention, they stayed doing the stop and flop much longer. So some things to think about would be, let's implement some proactive or preventative transition supports. So maybe this is giving the individual a helper task, maybe using first then phrases, a timer, visual schedules. We might teach how to gain attention appropriately. When we think about behaviors, we also need to think about what behaviors may look like or what we do about them in other environments. So something that we talk about is when a behavior happens at school, what do we do? So oftentimes parents will come to me and they'll say, well, my kid hit at school. And I have about a million questions when a parent tells me that, because again, I want to know the antecedent, the consequence, what strategies were tried. So I need like a whole lot more context. The parent, if there was a behavior that was reported one time, I'm not super concerned. If it is a pattern that's happening, it's problematic, it's becoming disruptive, then I become more concerned. So then I might coach a parent on how to request what's called an FBA, or functional behavioral assessment. And this is oftentimes something that is implemented in the school by a school psychologist or a behaviorist or some similarly titled individual. And this is when the teacher goes in and the school psychologist or behaviorist goes into the classroom, does observations, and tries to figure out that ABC data like we were just doing with those scenarios that I presented to you. After that, they're going to come up with, okay, this is the function. These are evidence-based interventions that help decrease those behaviors, and they're going to come up with a behavior plan. Sometimes it's called a behavior plan, a behavior intervention plan, a positive behavior support plan. It's all the same thing. So if this is occurring for your individual, I would consult with the teacher. You can request the FBA. You can also talk to the other people on your individual's IEP team. So talking with the special education teachers, speech OTs, PTs, and try to figure out like what is going on, what is happening, how can we support it. And don't forget, like we really need to focus on the preventative or proactive strategies, areas of skill deficit, making sure that we're using the correct intervention based on the function of the behavior as part of this plan that we're going to create. So the next section of this presentation I'm going to give is just some general positive behavior strategies. So it's not necessarily function specific, but these are just strategies that I think everybody and every individual, no matter what their diagnosis may be, could benefit from. So explicit directives is just kind of a fancy term for like being specific and using statements, not questions. So instead of asking your individual, like, do you need to go potty? Because that will result in a no response probably 90% of the time, we're going to say it's time to go potty. Rather than saying clean up the living room, clean up your bedroom, because that's a really broad, what does clean up mean? Then we're going to get really specific and kind of narrow with our directives. We're going to say put the clothes in the hamper, put the car in the toy box, pick up the dolls and hand them to me, rather than giving a really broad directive. Labeled praise, that means instead of saying good job or thanks, which are kind of vague, we're going to be really specific so that the individual knows exactly what they did that's getting them the praise from the adult. So then they know what to do again next time. So instead of saying good job or thanks, I might say, I really like how you're walking with your feet slowly on the floor. I really like how your bum is in the chair. Any type of really explicit, specific praise. We always need to establish reinforcers or rewards. So I kind of joke sometimes that I really like ice cream, but I'm not going to type psych evals for ice cream. I am motivated by my salary. And so just because somebody likes something doesn't mean they like it enough to do hard work. So that's where we have to be really careful. Like your individual might like a sticker, but are they going to do math and reading assignments for a sticker? We might need to really work on that. So establishing reinforcers and motivators is really important. I really like the idea of presenting the individual choices of a couple possible reinforcers. Hey, you got to do this math work. Do you want to earn this, this, or this? And letting them choose, because then you know it's something they actually want, and you giving them the choice gives them power and control, and then they'll be more motivated to work towards that. When we're thinking about it, reinforcers and rewards, they have to be given immediately after their desired behavior occurs. So if you have promised McDonald's if they go potty and it's 10 o'clock at night, you have to drive to McDonald's at 10 o'clock at night. So often I tell parents, don't make it something that's that big because you're not going to drive to McDonald's at 10 o'clock at night. Don't make it something that's really expensive. It has to be something that can be given immediately and very easily. Oftentimes our individuals are really socially motivated. So use that to your advantage. So cheering, getting excited, having a dance party. These are all things that we can give freely at any time. It doesn't cost anything. It's not going to be inconvenient or impossible or too expensive. I really like the idea of cheer videos. And this is like getting all the individuals' loved ones and friends and neighbors to send a really short clip like, woohoo, good job, Taryn, great job. I really like how you did X, Y, and Z. And so then that way you can say, hey, who do you want to cheer for you today? And if it's like Aunt Susie, then we can pull up Aunt Susie's video and play the video after the individual does the desired behavior. I want to talk about reinforcers versus bribes. So this would be, so if the behavior is occurring, and then you say, hey, you can have X, Y, and Z if you stop escalating, that is a bribe. So for example, if at a grocery store, the kiddo wants candy, you say no, they tantrum, and you're like, fine, take the candy so that they stop tantruming, you have just given them a bribe. This does not work for behavior change. This will actually cause your individual to have more tantrums every time they go into the checkout line in order to get the candy. So we don't want to do that. If you know that this is something that your individual does, then I would say, okay, this is what I expect from you when we go to the store. I want you to do X, Y, and Z. And if you do that, I will get you candy in the checkout line. So if you do positive behavior, then you can have candy in the checkout line. So you've kind of dangled the carrot ahead of time before the behavior has occurred, and you promise them this reinforcer of the candy if they have good behavior up until that point. And so this reinforcer is they do the expected or appropriate behavior, and then they get the reinforcer, the gum. We often use visual schedules and first then boards or first then phrases. This is an example. Can you guys see me on the camera? I have this first then board, and it says first bath, and then the star means a reward. And this is my example of a visual schedule. And so this is like a morning routine. It says bathroom, get dressed, eat breakfast, brush teeth, wash face, and then they can get a preferred activity, which in this case was a little bit of television before school. If you are not crafty and don't want to make your own, there's a website called Teachers Pay Teachers. That's fantastic. You can get a visual schedule or a first then board, or you can just Google image and create your own. A task analysis is, it kind of breaks down an activity into smaller steps. So for example, if we're teaching hand washing, it'll teach the steps of hand washing. If we're teaching laundry, it'll teach the steps of laundry. We can do this for showering or toileting. If you're doing it for showering, laminate it and stick it in the bathroom. These are really good for teaching a skill. I'm a timer nerd, so the next strategy is the use of timers. This is really good for times of transition. So if you say, and this is my timer here, you say like, hey, in 5 minutes, we're going to be all done play. And then as the time ticks away, so when you say 5 minutes, what does that feel like to an individual? It's an abstract concept. So with the visual time timers, you could say, hey, when there's a lot of red or a lot of blue in this instance on my slide, you have a lot of time left. But when there's only a little bit, then you only have a little bit of time left. And then you can accompany that with a verbal countdown. Like you got 5 minutes, 3 minutes, 1 minute. The picture on the left of the rubber ducky, that's actually an app. In the Apple Store, I think it's called Countdown Timer app. You can change the picture from a rubber ducky to there's like a little blue monster, some monster trucks. There's a free version that works just fine, but there also is a paid version of that. So giving choices and giving helper tasks. So giving a choice, if we're working on toilet training, it might be, hey, do you want to use the potty upstairs or downstairs if you have 2 bathrooms in your house? It might be that you lay out 2 outfits and you say, hey, do you want to wear the purple outfit or the blue outfit? Giving a helper task would be, it's really good for times of transitions, like at school in the hallway. So, hey, can you take this note to Miss Amy, and then when Miss Amy, it doesn't have to have anything on it, could be a scribble, but Miss Amy knows that when she receives this to give tons of excitement and praise. So then Miss Amy gets it, and then she's like, oh, thank you so much. That was a great job. And that helps the individual with like a focus and a goal for transitioning between classrooms. The use of natural consequences, this would be like if an individual makes a mess, they must clean it up. The one thing that we have to be careful of is that the individual doesn't really like cleaning and is making messes to be able to clean, because then it wouldn't work in that situation. I wouldn't be a mental health professional if I didn't talk about, labeling feelings and coping skills. So we want the individual to be able to say, like, I am mad, and it's okay if they're mad, but like, I will help you and we'll do coping skills together. So labeling them and practicing them, this is all in neutral moments. If your individual is tantruming, you don't want to be like, are you mad? This isn't, it's not a time for teaching then. The individual is too escalated. But we want to work on teaching coping skills. So like deep breathing, dragon breathing, smell the flowers, blow out the candle. These are all other names for deep breathing. Belly breathing or diaphragmatic breathing, progressive muscle relaxation, grounding techniques. These are all like real quick, easy, and free and on the person's body type of coping skills. Other people might say, oh, we'll go for a walk or watch TV, but you can't do those in the middle of class. So I like the ones that just use you and your body the best, but other ones can be used if you have that availability. They're just not great for like if you're at work or if you're at school. You can't watch a movie to calm down, for example. So there's a couple behavior systems that we hear about a lot. This is oftentimes used, like people hear about it in terms of classroom behavior systems. So there's what's called a token economy and a response cost system. The difference is a token economy that the child is given a reinforcer for appropriate behaviors, and then they kind of exchange them for a bigger reward. In a response cost system, the child can earn things for positive behaviors, but then if they do a challenging or a negative behavior, that thing can be taken away. But what research shows is that response cost systems are not as effective for long-term behavior change. So I'm all for token economy systems. I know I'm going through this fast, but I don't want to run out of time. Social stories are a really great intervention, especially for when we want to teach an individual like what to expect in a novel situation, how you're expected to behave, what's going to happen, what is the outcome. So a lot of times we use social stories in terms of when our individual is going to get a sleep study. Like, what's a sleep study? A kid doesn't have a schema if they've never had one before. They don't know what to expect. Is this going to hurt? What's this going to be like? Who's going to be there? So if we can present a social story and tell them what to expect, then oftentimes it reduces the anxiety around the situation. Miracle Dental is a local dental practice that some of our individuals go to, and they have an occupational therapist on staff that kind of helps create a social story ahead of their dental appointment, where they'll go through the steps and get familiar with the dental equipment and take pictures and create a little book. And then the family goes home and reviews the book leading up to the dental appointment. And then hopefully that results in a more positive dental experience. And then just behavioral resources to think about. So the book that I referenced earlier is listed here. It's available on Amazon. It's by Dr. David Stein, the Supporting Positive Behavior book. Dr. Velody, if you haven't checked him out, has a ton of wonderful podcasts. He did a couple podcasts with David Stein. So if you are not a book reader, don't worry about it. Listen to these podcasts. I think that you'll gain from it equal information. Oh, sorry, that was my time timer going off that I was playing with a second ago. So there's Dr. Velody's podcast at the top. And then I've done a few podcasts with Dr. Velody where we did one about like behavioral interventions and approach. We did one about throwing. And then we did one about like different behavioral health services that are available in Pennsylvania. So you could just look up Dr. Velody's podcast and you can search by term, but he has all kinds of podcasts on a variety of subjects. A lot of them are medically related to Down syndrome. So, any questions or concerns? Oh, I see that. Thank you for putting the link to Teachers Pay Teachers in the Chat. That's a great website. So you could search visual schedules or first then phrases, and it's just products that are made for families at a real minimal cost, and it supports educators, which I love. And they'll mail them to you or send you a file. Any questions for me? Again, if you want to see me in the Down Syndrome Center, just make sure you're up to date on your medical appointments. If I haven't seen your individual in over a year, we'll have to kind of redo that psych eval appointment, get some updates, and then once that psych eval or updated eval is completed, then we can do outpatient therapy sessions. If your individual's needs are more than what may able to be addressed through outpatient therapy, I can give referrals to the higher levels of care like wraparounds, ABA, or family-based.
If there's no other questions, thank you so much, Dr. Santamaria, for your time, and thank
Thanks,
you
of
everyone for
course.
coming. I hope you got some valuable information, and we'll be sharing our May speaker series soon.
Wonderful. Thank you for having
Thank
me.
you.
Thank you.